Hi, everybody. This course will review a longitudinal perspective on spasticity management across the lifespan in cerebral palsy. The speakers are Dr. Srinivasan, Hana Azizi, and Haegyung Kim. We are all pediatric physiatrists. This is our disclosure. Dr. Srinivasan will address the aging trajectory in cerebral palsy, challenges and indications for spasticity management. Dr. Hana Azizi will address medical and minimally invasive approaches for spasticity management in adults with cerebral palsy. And Dr. Haegyung Kim will discuss orthopedic and neurosurgical interventions for long-term spasticity and functional preservation. Dr. Srinivasan, please start.
Thank you, Dr. Kim. Thank you, everybody. Welcome. I will be talking about spasticity management across lifespan in CP, the aging trajectory in cerebral palsy. Next slide, please. Cerebral palsy, though considered a static lesion, presents with variability as the individuals get older. As we know, spasticity is defined as velocity-dependent resistance to stretch. It originates from the Greek word spasmos, which means to tug or draw. As a disorder of the sensory motor system, velocity-dependent increase in muscle tone is noted. Exaggerated tendon jerks due to hyperexcitability of stretch reflexes are seen. Increased muscle resistance is seen with faster passive movements. Common tools used to measure spasticity include the Tardieu scale and the modified Ashworth scale. Next slide, please. Managing children with cerebral palsy consists of various approaches. Therapies are used for stretching and strengthening weak muscles. Spasticity management is varied. It ranges from the use of enteral medications, botulinum toxin, and phenol injections, braces in conjunction with therapies. Operative management of spasticity includes intrathecal baclofen pump and selective dorsal root rhizotomy. Orthopedic procedures are used to address contractures and bony deformities. The focus of all these interventions is to improve the function of the individuals with cerebral palsy. Next slide, please. Indications for spasticity management are to address specific goals or needs that impact patient care and function. Improvement in muscle stiffness helps matching the bone and the muscle growth. It helps prevent or minimize coxa-valga, which occurs due to spastic muscles preventing normal derotation of the femoral head. Other goals may be to improve the sitting position, to have better fit of braces, or improved function, like improved gait after botulinum toxin injections or improved ability to type a keyboard. Pain control may be improved with spasticity management. It's not unusual for patients to complain of pain when they have the spasticity. A few words that have been used to describe this is it feels like a Charlie horse that never goes. Appropriate interventions can help with caregiver ease in activities, including hygiene, diapering, and better range of motion. The normal angle between the femoral shaft and neck is 125 degrees. The growing bones are susceptible to distortion by sustained pressure. Because of the increased force of the spastic muscles, excessive stress is placed on the bones, which leads to abnormal rotation. This is inhibiting the physiological derotation of long bones, which causes the coxa valga, with the femoral neck shaft angle increasing to 150 degrees. This also contributes to the windswept deformity typically seen with increased spasticity of the hip adductors and the abductors, leading to poor positioning, deformities, and pain. Botulinum toxin is a much utilized tool of the spasticity landscape. The peak age for use of botulinum toxin A is between 2 and 6 years. The peak age for orthopedic surgery being instituted to address the contractures and bony torsion are between 6 and 12 years. When limited responses are noted to targeted spasticity management, a washout period is recommended prior to the surgical intervention. Next slide. Spasticity not only impacts positioning, range of motion, but it also impacts patient growth, affecting the size of the limb, causing deformities, impacting function as stated. Spasticity increases during periods of growth, necessitating adequate interventions in these times. It may be difficult occasionally to differentiate between spasticity or dystonia, needing appropriate tool utilizations. Systemic conditions can increase or worsen spasticity or dystonia. Gastrointestinal conditions like gastroesophageal reflux disease, constipation, or gaseous distension can worsen spasticity or present with different posturing, which can make the diagnosis a little bit harder. Bladder retention or infections can worsen spasticity. Pain sources like dental caries, ear infection, tight clothing can contribute to increased spasticity or dystonia. Other challenges also include limitations in using higher doses of botulinum toxin, limited to specific types of the toxin that are being used. Providing continuum of care requires regular injections, follow-up therapies, which may be challenging due to various reasons, not limited to distance to travel, access to resources, and comprehension of the need for adequate follow-up. Continuum causes muscle stiffness, sustained muscle spasms, development of contractures, skin breakdown, which causes pressure ulcers and increasing muscle stress. As individuals grow, worsening musculoskeletal and neurological conditions lead to premature aging of adults with cerebral palsy, which characterize the early decrease in mobility and function when compared to the general aging population. One sees increased spasticity and mobility impairments related to progressive chronic conditions. Spasticity management is important to decrease injuries to muscles and joints and minimize accelerated decline in functional performance. There are numerous healthcare challenges faced by individuals with cerebral palsy, especially as they reach adulthood. Long-term motor deficits contributes to it. As cerebral palsy is considered a pediatric condition, there is a lack of training for clinical providers with having adequate expertise in managing patients with long-term impairments. There is a scarcity of rehabilitation options. Funding sources are limited as they grow older. Though a non-progressive lesion, cerebral palsy as a neurodevelopmental disorder worsens due to secondary complications of existing sensory, motor, and cognitive impairments. Next slide. Factors that affect the lifespan in cerebral palsy are varied. It may be related to the number of impairments and key disabilities, the severity level of the condition that the patient has. It can be because of mobility restrictions, feeding difficulties, the other associated features, including seizures, cognitive functioning, visual acuity, and the respiratory functioning. And I've just included a link for cerebral palsy effects through lifespan through Physiopedia, which people can look through and learn more about this condition. I would now like to invite Dr. Hannah Azizi to continue with the talk.
Thank you, Dr. Srinivasan. I will review medical and minimally invasive approaches to spasticity management in adults with CP. Treating spasticity in adults could be different than pediatric patients. The goals could be different, and also the outcomes could be different. there is change in spasticity and dystonia with age, meaning that dystonia tends to get worse, especially in higher GMFCS levels. It is rare to have dystonia without spasticity, and most of the time when someone has dystonia, they also have some elements of spasticity with it. Previous slide, please, still. Thank you. Here you see pictures, and also spasticity changes. Spastic muscles change with aging. Here you see two pictures of elbow, of wrist and finger flexors, the same muscle groups in a child and an adult. And you will see that with aging, spastic muscles are atrophied and fibrotic, and it's difficult to see the fascia around each muscle. And part of that, of course, is aging, but also they don't have healthy muscles at baseline. And in a 23-year-old, you do not expect to see muscles in a healthy person to be this much atrophied and fibrotic. So pain is common in adults with CP. And pain studies have shown that pain was not associated with GMFCS level, and pain increases with age and was a predictor of lower quality of life. Self-reported spasms were associated with increased pain as well. And pain is one of the main reasons that we treat, that we see adults with CP, or we treat their spasticity. However, it is important to rule out other causes contributing to their pain. Some cause some of the conditions related to aging, so for example, arthritis, and also spinal stenosis, which are common in adults with CP. Next slide. When we see adults who with spasticity, of course, we do a very good history and physical exam, but in assessing their spasticity and or dystonia, we have to make sure there are not other rule out to treat contributing factors, something as simple as constipation or acid reflux, GI issues, infection, and pain. And I just put something to review here briefly is that in spasticity treatment, we focus on inhibiting the uncontrolled reflex arc, which is the main reason for spasticity, which goes from muscle spindle to spinal cord. And in dystonia, we focus on improving inhibitory signals or decreasing the excess motor activity. Next slide, please. So when we treat spasticity, why we should treat that and how it should be treated. If adults with CP has some spasticity, but they are comfortable, they don't have pain related to that, they sleep well, and also it doesn't affect their function, we do not need to treat that. One of the main reasons that we treat spasticity in adults with CP is pain. And also it could affect their function, their hygiene care, and their activities of daily living. How it should be treated, we always start with the least invasive. However, it is less likely for them to respond to those treatments compared to pediatric patients. We start off with stretching, bracing. Therapy always is a main part of their treatment. Then we have oral medication, including but not limited to only the ones that we have here, baclofen, benzodiazepine, mostly for acute treatment and as needed, tizanidine, which could be used for pain when they have pain, especially with spasticity, dantrolene, which is a peripherally acting agent, clonidine, gabapentin, and Artane, they could be used for dystonia as well. And Sinemet, which is a dopaminergic, and also medication as well. Then we have a localized treatment of spasticity and dystonia, which is botulinum toxin and phenol injections. Then some ITB pump, SDR, DBS, and orthopedic surgeries that Dr. Kim will review later. Next slide. So I review cases, and the cases are different, and it could help also with learning what the reasons and how it should be treated. The first one is a 55-year-old with spastic quad CP GMFCS4, referred to us by ortho with a sharp pulling pain in right more than left groin areas and lesser degree in the proximal thighs and behind the knees for 2 months. She's GMFCS4 and uses lobster and crutches at home for very limited mobility. She had a fall episode before these symptoms started, and also had bilateral hip replacement 1 year before, but on recent follow-ups, there were no concerns. She reported muscle spasms and that her right leg crosses over the left leg and contracts at night. She couldn't sleep well. She couldn't sleep on right side. Most of these adults with CP, unfortunately, they do not receive any therapy. And again, we know that in adults with CP, they are more likely to have depression, anxiety, and other comorbidities. And she was on sertraline and oxybutynin. Next slide, please. Her exam was very limited due to pain, and I couldn't even touch the right leg especially. She was in flex position, the hips, and very limited hip abduction. And sometimes I'm surprised that with 2 examiners, we are not even able to achieve much hip abduction and how they do it at home by themselves. And also she had some tone in knee extensors, which I see that in adults with CP with aging, even though it could be first their hamstrings, sometimes it could be extensors as well, but mostly it's the flexor groups. And with time, they have stiffness in knee extensors and pain. And her knees were extended in wheelchair. So we did botulinum toxin injection, onabotulinum toxin A injection to bilateral hip adductors, iliopsoas, and very small dose to rectus because of the pain. Referred to PT and also wheelchair clinic. And later during her treatment, she was started on oral medication, but most of our adults, they do not tolerate side effects. Next slide. On her follow-up, she reported decreased pain and spasms more than 75%. Her legs do not cross anymore. She was able to sleep on right side. She walks a little more and negotiated the stairs with her physical therapist. And I was able to examine lower extremities without pain. Some improved passive range of motion. Again, something to remember is that in adults, we do not see a very big difference in range of motion after injections, but subjectively they feel better, and basically they have improved ADLs. She receives injection every 6 months or once a year, and she has improved, and now she does not get injections anymore. Next slide. This one is a 32-year-old with, again, spastic quad. She's a university graduate. So most of these patients are very cognitively intact and even high functioning. She has chronic pain in gluteal area. She has also a spinal cord stimulator pain for pain. Multiple musculoskeletal injections, right proximal femur osteotomy and removal of hardware. She has neurogenic bladder and a Tarlov cyst surgery. And also she's again on fluoxetine and gabapentin. So I included this because she has a pump. The pump is a low dose, but that's what she wants it at this level, a flex dose day and night. And for her, the goal for botulinum toxin injection is to improve left arm range of motion. And also she reported some toe curling, which only improves with toxin injection. Next one, please. This is just a table of the muscles that were injected, and also, as you see, like FDL, FHL, and FHL on right side as well. Thank you. Next one. So this one, again, a different story, a 41-year-old with dystonic quad CP GMFCS4, had multiple hip and spine surgeries and left wrist fusion, spasticity and dystonia in all extremities, limiting her upper extremity function, especially for driving her power wheelchair. So curling of bilateral toes, causing discomfort and skin breakdown, as well as teeth grinding. So that wrist fusion, and the wrist fusion was the left. So the driving with wheelchair would be the right side. the opposite. So she's on multiple seizure and psych medications such as risperidone, baclofen 10 milligram 3 times a day. The goals for her injection were to improve upper extremity range of motion and also being able to participate in therapies. She had also bruxism, so we did the facial muscles for that as well. And as you see, she's on, again, both psych medications and baclofen with not much improvement. Next one. So these are her injections, and so is the right wrist, basically left wrist is fused and right wrist. So she had her mother goals are more defined by her mother and therapist. She had increased mobility in upper extremities, teeth grinding completely resolved, and she's able to basically hold an adaptive cough and drink through a straw, which is sometimes the goals could be not big goals for patients, but for them, it's a big achievement. And parents are very happy even with this, or patients are happy. That's something to consider. So our goals from our point of view could be different than them. Next slide. So this again, different story for this 3-year-old with spastic quad GMFCS4. She had significant, again, she's also a university graduate, significant tightness in legs affecting hygiene care, and she had worsening of pain in lower back and legs. Uses a walker at home, was referred many times for ITB pump, but she didn't want to do it. She's on baclofen, sertraline again. Physical exam showed significant spasticity and contracture in flexor groups and also in her quads. She had very limited hip abduction and also poor hygiene due to that, and severe lumbar hyperextension and crouch standing posture. Next slide, please. So after injection, she felt less tight and also less pain in lower back and legs by 90%. Improved hygiene care. It was able to wipe after toileting, and walking and taking steps was a little more fluent. And she noticed there was decrease in her hyperextension, lumbar, improved bed mobility and sleep. And she has started receiving therapy at home. And finally, I was able to persuade her to go see some neurosurgeons because no amount of toxin injection could improve her basically her range and her quality of life. She has a pump now. She had some side effects with increasing the dose, urinary side effects. So she's on a very low dose, but she's doing well. Next slide, please. So this one is a 42-year-old diplegic CP, GMFCS2. And these are some patients that I have for 8 years. So when I saw them, they were younger. Muscle pain and spasms at night, mostly in hamstrings, difficulty with hip abduction, right ankle pain. She had an Achilles lengthening done and basically saw ortho for that and then was referred to us. She has history of DVT, and again, she's on fluoxetine 40 milligram. Next slide, please. So on exam, again, spasticity in hip flexors, hip abduction was normal. So again, something to keep in mind that for us, for passive range of motion, yes, I could achieve normal hip abduction, but for her actively, hip abduction was difficult. Again, spasticity in knee flexors and ankle dorsiflexion was only to neutral. And she has some tenderness over right Achilles insertion and calcaneus. So with the assessment that she has increased tone in lower extremities with spasms affecting quality of life, and also could contribute to her ankle pain, toxin injection was done to hip flexors, adductors, hamstrings, and gastroc muscles, referred to PT. Next slide, please. So her ankle MRI just showed that she had heterotopic ossification, likely post-surgical, and also tendinosis, and received a custom-made foot orthotics by ortho. But what she said is that I was smiling, and my husband asked me, why you're smiling? And I said, I had lived with spasticity for so long that I didn't know how life could be without it and not to have spasms. And she was told that she walks better. She had decreased basically tightness, ease of walking and taking the stairs. This is just subjective, more fluid movements when walking. and decreased muscle spasm at night, and also improved her sex life. She gets injection maybe every 6 or 7 months, and she's doing very well with that. Next slide. In summary, we have to discuss the goals of spasticity management with our patients and their caregivers, and also to remember that sometimes the tone is important for their function, and not every tone has to be treated. Thank you. I would like to invite Dr. Kemp to continue.
Hi, everybody. My name is Haegeun Kim. I'd like to address orthopedic and neurosurgical intervention for long-term spasticity and functional preservation. And as a pediatric physiatrist, I have been taking care of patients with cerebral palsy from infant to through the lifespan. And I realized that there have continuous musculoskeletal problems even after the childhood. So usually I see that early onset arthritis, which can happen even during childhood, pre-teenagers, and early osteoarthritis happens even 7 to 10 times higher risk compared to general population. And because of a chronic spasticity and muscle weakness, they have joint contractures. And then early premature muscle loss, which is sarcopenia, happens in younger ages. So for example, their calf muscle is about 22% smaller by preschool, but when they get older, by young adulthood, their calf muscle about 45% smaller. So it's continuous weaknesses happening. What case you think about orthopedic surgery for adults with cerebral palsy? Mostly continuous pain from the arthritis, and most common pain in adult with cerebral palsy is leg pain. And I start to see a lot of patients is complaining foot pain, and mostly those patients has foot deformities. I start to send the patients to EMG nerve conduction study. I found that they are not simply having foot pain, but from the peripheral neuropathy, from the foot deformities, and cervical myelopathy. So, and there's also 5.4% prevalence of any osteoarthritis in adults with CP aged between 18 to 30 years old. And functional deterioration happens because of pain and because of muscle weakness. And chronic spasticity also causes a significant liver arm dysfunction. So these pictures I borrowed from my colleague, Dr. David Roy, and the left picture shows that this patient has a left window swept deformity from the left hip dislocation. As you see on the bottom x-ray, his left hip is completely dislocated, and he has a very narrow hip abduction. And before we think about the surgical intervention, we have to control the spasticity. So Dr. Roy started the oral baclofen, gabapentin, and diazepam to control his muscle spasticity along with the start response. And then they choose 3 different orthopedic surgery. Number 1 is a reconstructive surgery to left hip, and also bilateral distal femoral extension osteotomy for the significant femoral intervention and tibial torsion. And also he did perform the patella and tibial tubercle advancement, since a lot of patient has high riding patella and the significant knee contractures. And this patient also has 39-year-old male with a severe pain in his right hip, which doesn't allow him to sit on the wheelchair. After the x-ray on the left side, there is quite significant arthritis progress. You can see bone on bone joint on the right hip, which required total hip arthroplasty. And then he become wheelchair bound again. He was able to sit on the wheelchair without severe pain. And this patient is 32 years old, right hemiplegic cerebral palsy, who came with the chief complaint of a right hip stiffness rather than spasticity. And the patient was followed by orthopedic surgeon regularly when she was young. However, when she entered adulthood, there was no continuum of care. And then when the x-ray was done at 32 years old, you can see left side of x-ray, significant heterotopic ossification, which is matured. And Dr. Roy brought the patient to the surgery, and they resected the bone formation around the joint. After then, she was able to take steps again, which made her be functional. And then this patient taught me a lot about the adult cerebral palsy. And then she is very vocal. And her chief complaint was, I cannot walk because of pain and I have a severe muscle stiffness. And I think as a physician, we have to listen to patient. She's not complaining spasticity, but she keeps saying muscle stiffness and I have a right knee pain. I used to walk like you, but now I have to use bilateral crutches because of pain. And you can see she has a liver arm disease. She is walking with the low strength crutches, and she has quite significant sarcopenia. When you take a look the right side, her leg MRI, the muscle bulk is very small. And however, her orthopedic surgeon couldn't understand her right knee arthritis, and he just keep delaying the surgery, and her function continuously deteriorated at the time. And I had to work with orthopedic surgeon and for her to go to right knee surgery. And I was meeting this 50 years old female with GMFCS2 and left hemiplegic CP who is going into GMFCS3 because of her left knee arthritis. She developed the left knee arthritis at 40 years old. She was a teacher, but she is no longer working as a teacher because of her functional deterioration. And she started to use a scooter for her long distance walking. And she never been on any antispastic drug until she developed the pain and muscle stiffness around 40 years old. And her neurologist was doing botulinum toxin injection to her left leg. And later, she was brought to orthopedic surgeon because of her left knee started swollen and has a severe pain. And orthopedic surgeon found that she has quite significant osteoarthritis. And then she was brought to me just before the orthopedic surgery in July this year, and we had a long discussion, and I recommended or I emphasized the importance of a spasticity management prior to surgery. And she's increased her oral baclofen dose, and she went to surgery. And also I recommended for her to call me with any muscle spasm, and we had a follow-up visit at 1 month after the surgery. She had a quite significant muscle spasm, which doesn't allow her to take steps. And I recommended to start tizanidine to control the painful muscle spasm. And I followed again in 1 month, which means 2 months after the knee surgery. And now her significant muscle spasm pain has been controlled with increased oral baclofen and tizanidine. She's walking again with very minimum muscle spasm / spasticity. So her function came back to previous, not completely previous level, which was GMFCS1. Now she's at least GMFCS2. And as I discussed earlier, our patient developed the peripheral neuropathy from prolonged postures. They lose their function from that, and there was a developed pain. A lot of patient has carpal tunnel syndrome from the prolonged posture at flexion and extension, and also they developed the ulnar neuropathy because of prolonged posture. And this is all confirmed with EMG nerve conduction studies. And as I expressed that, a lot of patients, the most common pain in adult cerebral palsy is a foot pain and leg pain. That's more from the peripheral neuropathy and muscle weakness and spasticity. You have to send your patient to rule out the peripheral neuropathy when they complain foot pain or leg pain. And the management-wise, we can continuously use a splint, brace, and spasticity management and orthopedic surgeries. And this patient is showing severe liver disease dysfunction with external tibial torsion, pes planus, and increased femoral anteversion. So you can see better here. So this patient has quite significant liver dysfunction from the chronic spasticity. The treatment was only physical therapy until we met him. So we use this slide again. So spasticity in adults with cerebral palsy. Is this real spasticity? All of muscle stiffness is a spasticity? We start to have the questions. So is spasticity progressive with the aging? Because a lot of patients still complain spasticity. Let's talk about spastic muscle with the aging. So when the patient is young, their muscle is still contractile. So we see reflex-induced resistance, which means active contractile tension, increase muscle tone. And they have exaggerated tendon jerk and they have clonus. But as they get older, the chronic spasticity causes contractures in spastic muscles. And there is decline, reflex, induced resistance due to rheologic phenomenon. And it enhanced viscous reaction, causes a stiffness, contractures, fibrosis, atrophy. I'm going to talk about rheologic phenomenon a little more. So the rheologic phenomenon is when you think about the starch. When you try to cook with the starch, you put the water in the powder starch, and then you start up starch, and it becomes smoother. But Dr. Azizi called me, so I tried to answer to her phone. I stopped stalling the starch in the water, and 10 minutes later, I came back. I am not able to stir the starch in the water anymore. It become very hard. That is a rheologic phenomenon. And also immobility. When you walk around a lot or when you move your body, in our body, there's so-called hyaluronic acid, which is a high molecular weight glycosaminoglycan, is working as a lubricant. But if you don't move a lot, hyaluronic acid increases in the extracellular membrane and viscosity is increases. Therefore, hyaluronic acid lubrication activity gets decreased and muscle becomes stiff and contractures and fibrotic and atrophic. So if you don't move, your body is going to be stiff, especially our patients with cerebral palsy. When they become grown up, they don't go to school anymore. They have no physical therapy or occupational therapy given regularly, and then their activity is very limited. Therefore, immobility increases. Therefore, our patient start to develop more rheologic phenomenon, which causes significant muscle stiffness and contractures. So this patient is showing that example. When I met him at 18 years old, he was at least his walking is very crouched but fluent. But 10 months later, after he graduated the high school, look at his walking, how he's walking. He's barely taking steps because he was sitting in his on his chair in his room every day, all day long, over 10 months. So mobility is extremely important. So how to manage increased muscle stiffness spasticity in adults with cerebral palsy. As you see, we have to enhance mobility. Therapist has to be applied, participation has to be applied to prevent muscle stiffness from rheologic phenomenon. So my adult CP clinic, the most common prescription is dancing, yoga, Pilates, participating any kind of sports activities, and massage. And we have to also address and treat pain sources. So orthopedic surgery will be applied for severe osteoarthritis, liver dysfunctions, and contractures. And we have to still leftover spasticity or increase the dystonia with the chemoneurolysis, as Dr. Azizi addressed, and intrathecal baclofen can be applied for severe dystonia and spasticity, and adult CP also can have a selective dose rhizotomy and deep brain stimulation for severe dystonia. So I like to discuss this case. He is a 23 years old male with intrathecal baclofen pump. His first pump was implanted at 14 years old, and reimplantation happens at 20 years old. At that time, meanwhile, he had bilateral hip reconstruction surgery at 11 years old and spinal fusion at 14 years old. And around after the spinal fusion, he started pain, but the pain became very severe at 18 years old. Meanwhile, he has to go through a transitioning program. So when I met him at my adult cerebral palsy clinic, he was 20 years old. And he was showing very severe, painful expression. And although we were controlling his spasticity with intrathecal baclofen pump, his pain causes more spasticity. We have no way to control his spasticity. Also, we couldn't find a pain source at all. And we started to include pain management. And bupivacaine was included in intrathecal baclofen pump. That solved all the problems. He become very quiet. He has no painful expression. His spasticity was controllable with his usual intrathecal baclofen dose, less than 170 microgram per day. So we need to think about significant pain control for patient who has a severe spasticity when they become adults. And as you know, 87% of adults with CP has pain problems. Now let's talk about the deep brain stimulation, which we directly go to the place where we can control the tone. This was designed by neurosurgery, and we are going to basal ganglia area. And for Parkinson's patient, we go to the with the electrodes close to the substantia nigra, increase the dopamine production. So let's talk about our patients with severe dystonia with the deep brain stimulation. So with the adults with the CP, they start to apply deep brain stimulation. But as you know, deep brain stimulation is more effective to primary dystonia, such as DYT1 dystonia. Cerebral palsy case is a brain lesion is very heterogeneous than homogeneous. Therefore, the outcome is not as effective as in pure dystonia patient in such as dystonia, primary dystonia, DYT1 dystonia. So they start to think about different ways to control the involuntary movement. But let's review this study. Dr. Kim and Dr. Park's team did a 2-year follow-up after they put DBS in the globus pallidus area, and that still shows dystonia severity improvement, but disability didn't improve that much. And then there was a pilot study with 13 adults with cerebral palsy with chorearthrotoid movement, which showed 24% motor improvement at 1 year, and they showed better function and better pain management and quality of life. However, that was not very sufficient, so recently they start to put the electrodes close to cerebellum. Actually, this study was done in superior cerebellar peduncle, DBS. And why cerebellum? Because cerebellum is a promising neuromodulation target for Parkinson's disease, dystonia, and tremor. So according to this study, 12 months follow-up showed 30% dystonia decreased and spasticity and improved the quality of life without hampering the cognition. Let's talk about selective dorsal rhizotomy. So selective dorsal rhizotomy has been doing great job for mostly diplegic cerebral palsy. Long-term outcome studies showed that there is continuous tone reduction into adulthood, but variable function and need for later orthopedic care. And let's talk about the adult case. There's not much study done for adults with cerebral palsy, but when I look at the T.S. Park's team, they did publish the with the 21 adults with spastic diplegic CP who underwent SDR as grown-ups, and they had a follow-up from 4 months to longer term, but the average was 17 months follow-up after the SDR done in adults. And it shows decreased spasticity in all measured lower extremity muscles, improved the passive range of motion, and improved the GMFM such as crawling and kneeling, and also subjective improvement in ambulatory ability, coordination, quality of life, and independence. But no complication in that group were documented. So we recommend SDR for palliative care or easy care, or continue to help their functional condition. So we try to prevent their functional deterioration. But there's not much studies. This is my case who had SDR by T.S. Park at 5 years old. And when I followed her 2 years later, she has shown significant crouch posture with a little bit of liver dysfunction. But this, then I was following her continuously. When she hit her growth spurt, she was showing very severe crouched gait and crouch posture along with the liver dysfunction. And she had to go to femoral osteotomies and tibial osteotomies to improve her liver dysfunction. Let's take a look. She was at the time 12 years old.
Well, now you come back. But she looks so good. Now you come to me. Walk the back again. Oh my God.
You guys can see her severe liver dysfunction improved her knee flexion, get improved quite a bit. So even though SDR was done, they have a continuous follow-up and they have more management in their progress in their muscle and bone. And this is my patient as a grown-up. He's a 26-year-old male with known cerebral palsy, GMFS2, came to my clinic, adult cerebral palsy clinic, to discuss further orthopedic surgery. He had SDR at 2.5 years old by Dr. T.S. Park, and he had multiple orthopedic surgery for soft tissue lengthenings, but however, he still has quite significant gait abnormalities. And you can see his left side is weaker than right side, and he has liver dysfunction, internal rotation, tibial external
Come back.
torsion, and then or pes valgus. And then we have to address this his bone deformities. However, I have a hard time to find out orthopedic surgeon who understand his condition, and unless I go to pediatric orthopedic surgeon, it's going to be very hard for me to discuss his needs with adult orthopedic surgeons. So summary, spasticity management across the lifespan in CP is, as we discussed, when they were young, we are addressing their spasticity and muscle weakness with therapy and injections and brace and orthopedic surgeries. After then, there is a big gap since we don't have that much transitioning program, and their cares are pieces, not the total comprehensive care. Therefore, a lot of patients start to deteriorate their function, and they have a depression, and they have a decreased endurance and fatigue, and their own medication to control their mental health issues, but some medication causes more spasticity or dystonia, such as Prozac, which is fluoxetine. So if you, after they started medication, they cause more severe spasticity, you may switch to a different SSRI. And then we need to continue chemoneurolysis based on their needs. And they start to develop the pain because of early onset arthritis, myelopathy, and they have chronic pain issues, which should be addressed and treated. And they also have rheologic phenomenon from the decreased mobility. And these all the things has to be addressed to maintain their function. And in adult CP care should be also comprehensive team approach. So team-based continual care with focused expertise, that's what we need. And they need ongoing monitoring and surveillance are essential. While I was preparing this talk, I was thinking we should really have a surveillance program for their hip joint and knee joint continuously, just like hip surveillance when they were young. And we appreciate your attention to our talk. This is the end of our talk, and thank you very much. I hope that you guys earn something from our lectures. Thanks a lot.